Are we good?
Yeah.
Hi, good evening. This is Fertility Fact or Fiction. I am your host, Dr. Rahi Victory, and we are having quite a technical kerfuffle here because we can now broadcast on TikTok, except we didn't realize that our software doesn't broadcast to TikTok. And we figured that out 1 minute ago. So sorry for the laughter at the start of the show. Welcome to Fertility Fact or Fiction. We do finally have a new study to share with you guys tonight. There are a couple of new ones that have come out that are kind of interesting. So over the next few weeks, we'll share some of those with you. And we have some very, very exciting guests that are going to be joining us hopefully very soon. So we have a geneticist coming to talk about PGT in the new year. And I am very much praying that one of the very major women's nutrition social media stars and gurus will join us hopefully next week or the week after to talk about how to prepare for the holidays from a fertility nutrition perspective. So I think that'll be a huge show. She's got a tremendous following and I'm very excited to speak to her. She has amazing posts and does a lot of great work for women out there who are struggling. So tonight's topic is oocyte maturity, oocyte fertilization, and cleavage stage embryo morphology are better in natural compared to high-dose gonadotropin stimulated IVF cycles. So I know I put a post out there on Instagram for you guys to check out talking about whether or not a high-dose protocol was better than a low-dose protocol or a no-dose protocol, in other words, natural IVF. And we've talked about it on the show a lot lately that we are backing away from using high doses and using lower and lower doses. But the question still remains, does any dose of gonadotropins actually worsen your outcome because you're kind of forcing multiple egg development, which is not a natural process. And so this is kind of one of the larger studies on this topic, looking at the outcomes in terms of does a natural cycle where they gave them literally no meds result in a better outcome than a stimulated cycle where you're giving them the normal gonadotropins. And interestingly, they call it high dose gonadotropins, but it actually was like relatively low dose by North American standards. These patients were getting 150 to 300 units of marional. And so it's a relatively low dose of medication in Europe. So we'll jump into the study and I'll show you guys what we found. So in this particular study, they reference the fact that previous studies have looked at this and shown on different levels that there may be a negative impact from taking medications on the outcomes in terms of the quality of the eggs, the quality of the embryos that you get. No one's shown a negative impact on live birth, but there may be an impact on the embryo quality. Now, I'm not proposing this to anybody out there for all of you to go abandon your stimulated cycles and just do natural. There is a value proposition that all of this ignores, which is if you can make 5 or 6 embryos and your age is a factor, you have to account for the fact that you need to get genetically normal embryos, and it can take several tries, and even natural cycle IVF, although we have very low pricing for it, is still expensive. So you don't want to just jump into this and say, oh, I'm abandoning what I've been doing and all the tried and tested approaches to things. But the question is, what about for those people who don't do really great when they do stimulated cycles or have compromises in their ovaries? Is natural cycle a viable option? And if it is it better or is it worse? So they reference one study from 2017 with 14,185 natural IVF cycles. And they showed that the fertility was better in those cycles than it was in the stimulated cycles. So based on this, they wanted to kind of relook at this and see what about the quality of the embryos, what if they were doing fresh transfers and things like that to see what the difference was in outcomes. So essentially they did a retrospective study, so they took their data and looked backwards at it. This was not looking forward. So retrospective is not as strong a data pool as prospective, and it's certainly not as strong a data pool as doing a randomized controlled trial. So take everything we're about to say with a significant several grains of salt, okay? So essentially what they did was they were at a hospital in Bern, Switzerland, Bern. And what they did was they looked at cycles where patients did not have any significant factors like endometriosis, testicular sperm extraction, severe fibroids, any major issues. These were kind of garden variety patients going through IVF. And they compared the ones that did just a natural cycle, and I'll tell you how they did that in a second, versus the ones that did a stimulated cycle. So in their natural cycle, they just monitored patients until they had a follicle that was 18 millimeters. They triggered with 5,000 units of HCG. 36 hours later, they did a retrieval, and then they did ICSI for everybody. And on day 2 or day 3, they did a fresh transfer. Okay, super critical because these days we're doing mostly frozen, so this was all fresh. And they didn't wait for a blastocyst. They just went bang, day 2 or day 3, we're popping it in there. In the stimulated group, they used anywhere from 150 to 300 units of merional. And with that, they grew multiple follicles. When they got the follicles to roughly the right size, they then decided to go ahead and do the trigger shot. The trigger shot again was just HCG. They retrieved the follicles. Because of the laws in Switzerland, they selected 1 or 2 follicles, and they only grew those ones into embryos with ICSI. And then on day 2 or 3, again, they did an embryo transfer with those fresh ones. So let's just kind of analyze that for a second. In a natural cycle, IVF cycle, you're not getting very much stimulation at all. So your estrogen levels are going to be normal. Your progesterone levels are going to be reasonable. You're not going to have an artificial early rise of progesterone. There's very little to screw up the cycle. So from a fresh embryo transfer perspective, yeah, there's no question those are set up optimally for pregnancy. In a stimulated cycle, you do have to remember that if they made a lot of eggs and you're only using 1 or 2, some of those patients may have endometrial asynchrony. Some of those patients may have high estrogen levels. Some of those patients may be hyperstimulating even a little bit. So you are at a higher risk of having unfavorable circumstances for implantation of an embryo. So this is not really an apples to apples comparison. An apples to apples comparison would have been freezing the embryos on day 2 or day 3, let's say, from the natural cycle, freezing the embryos from the stimulated cycle, getting people ready again, and then transferring in embryos one at a time from fresh or from frozen. You could maybe argue that in the fresh natural cycle one, you could have done that fresh, and in the multiple cycle one, you could have done that frozen and still compared those. But the most fair comparison would be to get the eggs, make them into embryos, freeze them all, so they're all being treated the exact same, and then do frozen embryo transfers and see what the difference is. So a little bit of, not ideal methodology in terms of what they did here. Again, it's retrospective, so that's not quite the same thing. You'd have to look prospectively at this, and that just wasn't part of their protocol. And then what they measured was how many eggs were mature based on the ratio of eggs to retrieval, how many zygotes were created, which are embryos, what the implantation ratio was, and what the live birth ratio was. So interesting data points, and I want to kind of jump right into the data. So I will show you the first chart. So we can screen share. Yeah, we're good? All right, perfect. And I'll grab my trusty little pen here and set up drawing and maybe change the color so people can see what I'm doing. Okay, so if you can see there on the screen, in this chart, they're basically showing the 2 different groups. So NC-IVF is natural cycle, and then CIVF was the stimulated cycle. And so overall, they had 419 patients. They had 783 cycles. There were some patients that had more than 1 cycle. So there were quite a few in the natural cycle IVF group, 52%, versus just 16% in the ovarian hyperstimulation group. So the most important thing here is looking down at the total number of oocytes retrieved. It was 495 in the natural cycle, 1,615 in the stimulated cycle. So these are hugely different numbers. Keep in mind that there were way more people in those natural cycles, 616 cycles in the natural cycle group versus only 167 people, or sorry, 167 cycles in the stimulated group, but way more eggs, nearly quadruple the number of eggs in the group that did the conventional stimulation versus the group that did the natural cycle. So that's really important because you are getting way less eggs. And again, there is a value proposition that's really critical here. The number of eggs, or sorry, number of cycles with at least one egg retrieved. So 80% of cycles from the natural cycle, which means you are going to have some patients where you just don't get an egg. And this is versus 100% in the other group. Super cool about this study, and I loved seeing this because this is something we're probably going to run a study on. They flushed in this up to 5 times for each follicle. So if they went in to get an egg on the natural cycles and they weren't able to acquire an egg, they flushed out the follicle until they were able to get one. That's the first time I've ever even seen that in a study. So I think that that is wonderful that they have it in there. Because you do frequently have to flush when you're dealing with a low number of follicles, and it's something we do for all of our patients who have less than 10 follicles, because we know that some of them just won't come out. If you're over 10, we're good because we know we'll get lots. But for some reason, when you have a low number of follicles, they don't always come out. So this is actually quite impressive that they were able to get 80%, but at the same time, remember, 20% of patients are going to go through the whole process and get nothing at the end of it. So that's important to keep in mind and remember. Conversely, 100% succeeded when they did the stimulated cycle. The rest of this stuff here, not really critical. I'll flip into the next chart and show you that one. Okay, so this is the really important stuff. So in the first kind of chart here, you can see natural cycle IVF and the conventional or the stimulated cycle, right? So the mature oocyte ratio is right here, 89% versus only 82% in the group with the conventional. So in other words, there was a higher percentage by a small amount that had mature follicles in the natural group compared to the stimulated group. Now, obviously that makes a lot of sense because when you're doing stimulation, they're not all going to be the same size. You're going to get some immature eggs, you're going to get some mature eggs, and if you're not careful, you're going to get some post-mature eggs, which are terrible, by the way. So you get more of a chance of just getting that solitary mature follicle when you're doing a natural cycle. How high is that chance? So if you look at the number right over here, it's an 80% increase, 79% increase with the crude odds ratio. And even after they adjusted for the confounding variables, they got a 79% increase, and it was highly significant, a p that was less than 0.001. So that's pretty robust data to indicate that you do have a higher percentage chance of ending up with a mature follicle. The zygote ratio per mature oocyte is how many embryos did you get per egg that you retrieved. So again, you can see here in the natural group, it's 79%, and in the stimulated group, it was only 71%. So you are going to get a higher ratio of embryos per egg retrieved, and it was per mature oocyte, so not just those immature ones, if you do the natural cycle. This is huge. This is not data I've seen before, right? So yes, it is possible for some patients to end up with more embryos, percentage-wise, from a non-stimulated cycle than it is from a stimulated cycle. What about the group that has cleavage stage embryos? Well, here's where it starts to really get interesting, right? So here and here, you can see they're both 97%. So how many of these eggs turned into embryos that grew to like day 2 or 3? 97% in both groups. So you're still going to end up with the same number of embryos that are available for, or number of patients that are available to have embryos on those days. And then the rest of it was essentially the same there. Okay, what about this part? Well, this is interesting. So then they decided to look at the quality of the embryos that they were producing. And they had some interesting scores. So one is how many cells are in there, which we call blastomeres. Next one's a fragmentation score, which is super important to embryologists. They score embryos on the degree of fragmentation in the embryo. It's one of the very important characteristics. And then they had something called a symmetry score, which is the uniformity of the size of the blastomeres in the embryo, right? So keep in mind, these are like 8 cell, 6 cell, 4 cell, and so on, 10 cell, 12 cell embryos. So we're not talking about blastocysts here, right? So when you look at this, you can see that in the natural IVF group, it was 52% with 4 blastomeres, 36% in the conventional group. The number that was less than 4 or greater than 4 was 48% and then 64%. So when they looked at the odds ratio, they're showing that there was a doubling of the rate that had 4 versus less than 4 or greater than 4 when you were in the natural IVF group. So you're going to get a higher number that had what they anticipated was the right number of blastomeres, okay? So that's really important. It's a doubling of that rate. The fragmentation score was way higher in the group that had the conventional. So if you look down here, you can see that they had 49% of the patients in the conventional IVF group that had a score of 1 to 3 versus only 33% in the natural IVF group. So they're actually getting better quality embryos because there's less fragmentation in that embryo. How high is that? An 87% increase in the group that had the natural cycle IVF, highly significant. Your p-value is less than 0.003. So that is amazing, okay? And then the symmetry score, which is not a huge issue, actually wasn't clinically significant, so they are statistically significant. So that didn't actually show any difference. They got the same score in both groups. So where does all this leave us? Well, essentially, when you go through all of this, and I can stop sharing now, the bottom line is that it looks like for some patients, the natural cycle IVF approach is a good approach. Who do we use it for? Well, we use it very frequently because I actually love natural cycle IVF. We have many patients who have not been able to succeed with stimulation. Their eggs don't respond well to the meds. Their ovaries don't respond well to the meds. Some women who are perimenopausal, you can pound them with drugs or you can give them almost no drugs. They're still going to get the same rate. You're going to get 1 or 2 eggs. So why would I give someone thousands of dollars of medication, potentially harm the egg quality? I do say potentially, we're not sure, but it's possible. When I can charge them roughly the same for just doing 2 natural cycles of IVF, minimal injections, and then just fire ahead and get the eggs. And I will say, in our experience, that the embryo quality is always amazing when we do natural cycle IVF. So, is this for everybody? 100% no. This is not for everybody. Remember, if you're capable of making 10 eggs, 12 eggs, you can make good quality eggs with stim, you should. That's a total no-brainer because making 1 is not going to necessarily give you enough embryos to yield the result that you want, which may be 1 kid, 2 kids, 3 kids, whatever that is for you. But in certain cases, especially when your conventional stimulation has failed or you have severely diminished ovarian reserve, this makes a ton of sense because it looks like you can potentially get better embryo quality, less impact on the eggs and the embryos, and maybe that's going to result in a better outcome in the end. They didn't show that the live birth rate was higher here, so keep that in mind. That's important. But it would be very, very interesting to look at a randomized controlled trial run the right way, where we did natural cycle IVF, we grew the embryos out to day 5. We did conventional IVF, we grew the embryos out to day 5. We take those embryos and we put them back in a neutral frozen embryo transfer protocol and see which one yields the best result. So is it a fact or fiction that natural cycle is better than conventional IVF? Well, it might be a fact for certain people, and it should definitely be considered for patients that are struggling when they take the medications. One thing is absolutely for sure, the more data that becomes available, people that are getting pounded with drugs with super high doses of medications, you're not going to do well and you shouldn't be taking those super high doses. So I hope you enjoyed this segment of Fertility Fact or Fiction. As always, we will be very open to feedback. And if you have comments, questions, I know there was tons of people asking about this online, make sure you let us know and we're always open to answering those questions. So we're going to take your questions live now, and I'm sure there's a bunch. And I want to say very quickly, thank you to all of you and anyone out there who has been watching our YouTube or our TikTok. Our new TikTok video just went over 800,000 about an hour ago. So that's been tremendous for us, very rewarding when stuff goes viral. So we're really excited about that. So on behalf of Tarek and myself, thank you very much. And a huge shout out to my very good friend off camera, Tarek Ibrahim from Ibrahim Strategies Group, who drove with me last night to St. Catharines to go attend to something we needed to attend to. And we had a great evening, and I appreciate you very much. So thank you for coming, buddy.
My pleasure.
And considering I basically fell asleep on the drive back, I couldn't have done it without you. So yeah, thank you for that. All right, fire away.
Hi, Dr. V&T.
Okay.
Got my first betas today
Okay.
at 14 DP 5DT,
Yeah.
and it's 1526. Is there a chance it could be twins? Was a single for a hatching blast?
Yeah, there's a chance. I mean, it's probably not a sky-high chance, but there's a chance. I mean, that's a pretty high level. And if it was a hatching blast when they put it in, that does increase your chances. So yeah, you could definitely have twins. It's possible. I wouldn't put a percentage on it because that's not predictive, but it's a possibility for sure.
Hi, smiley face.
Okay.
Post FET.
Okay.
I've done 2 beta HCG.
Okay.
First 390, and 4 days later 2000.
Okay.
We'll have 6-week ultrasound this week.
390, first one, and then 4 days later, 2,000. Okay, so we're all going to do the mental math. So roughly 400 should go up a minimum of 60% in 48 hours. So that would be 240. So we'd be looking at 640. And then 2 days later, again, another 60%. So yeah, they're well into the normal. They're in. You're in a good range there. Yep. Okay.
What should I expect for 6 weeks ultrasound? I have had 2 counts of bad cramps.
You should expect to see a fetus in the right place, hopefully. I mean, you've got a normally rising beta. Typically, if it's an ectopic or a miscarriage, it won't rise normally, but it is early, so there are possibilities. So you should be expecting to see a sac inside the uterus at 6 weeks. You should see a fetal pole, which is the fetus. You should see a yolk sac, which is what the fetus feeds from initially. And you should see a heartbeat if it's a good ultrasound.
One comment here.
Okay.
I'm completely cheating, but it's nice.
All right.
Just want to say that I love your philosophy, Dr. V,
Oh, wow.
of
Okay.
sharing science straight from the source and free advice from a fellow scientist. Heart, 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 heart.
Oh, very cool. Well, thank you, fellow scientist. I don't know who that is, but
I told you I'd like it.
yeah, that's very nice. You have to make a note of who that is and share it with me.
Okay,
Yeah,
I will.
cool. Yeah. I never get to see who you guys are. We need a new TV set up so I can see who it is up there. Yeah.
I don't mind.
Black Friday. I know you want one. Yeah, yeah.
Hi,
right.
Dr. V&T.
Okay.
After the T, there's a heart.
Okay, yeah. Of course, yeah. The love is always for you. Yeah.
I get some love. I won't say all of it. There's some
Yeah.
V love here. I have 2 questions
Okay.
about the timing of things around my 3-month Lupron depot.
Okay.
Number 1, can the SHG be done anytime while on LD, or it has to be early in the cycle?
On LD,
On LD,
I wonder if that's someone Persian because LD is a birth control pill in Iran. Yeah, you can do a hysterosalpingogram at any time during a cycle as long as there's no chance that you're pregnant. So if you're already on Lupron, yes. If you're on birth control, yes. If you're not on those things, it has to be done before day 12 so that you haven't ovulated yet.
could LD be Lupron depot?
Oh, maybe. Yeah. So on that, it would be fine. Yeah. Yep. There you go. Hey. Yeah, it could be Lupron Depot. Yep.
I could do
Yeah.
that on that.
There you go.
Hi, Dr. V. Could you tell us more about DQ alpha testing and whether this test is worthwhile when there are normal NK cells and the others tests are normal, continued, and recurrent chemical pregnancy with PGS embryos?
Okay, so first of all, if you have recurrent pregnancy losses or implantation failures with PGT tested normal embryos, you really need to see a high level reproductive endocrinology specialist who either has experience in reproductive immunology or you need to see a reproductive immunologist. So, full disclaimer there. DQ alpha is super controversial. Okay, so essentially, it's an analysis of whether you share a specific protein with your partner. And if you do, there is one study that says this is the worst thing ever and it's a disaster and it'll never work and all that stuff. At the same time, there's another study that showed that it had absolutely no difference whatsoever. And then there's another study that said it's not DQ alpha, it's DQ bravo. And that one is the one that actually is the more meaningful of the two. So the truth is we don't really know. If you talk to reproductive immunologists, they'll say, yes, it could be important, and therefore you need to be treated for it. The appropriate treatment is either LIT therapy, leukocyte immunization therapy, or subcutaneous IG. Some people are now advocating for heparin as well. If you don't believe in it, then you don't believe in it. So I'm not sure what to make out of it. You know, it's one of those things where we get the result when we do our Fertility testing, for better or for worse. And the reality is, if it's there, I kind of am obligated to treat it, right? Because we don't know if it makes a difference or not, but I can't just ignore it. Because if it doesn't work, people are going to say, why did you ignore it? So we're kind of obligated, since it's there, to address it, and I do. Is it working? Yeah, it does work. So we have had a lot of success in patients where they've previously had failures. So that would be my full-fledged answer. First, if you've had multiple failures, make sure you're dealing with someone that knows how to deal with that specific realm of fertility. And then secondly, yeah, I mean, we do test for it with our fertility testing. So when I get the result, we do treat for those patients that are positive.
So remember that first question with the LD?
Yeah,
Remember how she had two questions?
yeah,
So before she could type her second question,
yeah. It cut it off.
no, two other questions came in.
Oh, okay.
So we didn't finish number two.
Oh, okay. All right. Finish number two.
So
All
we'll
right.
go back to the number two of the question.
Okay.
Number two, I haven't received my fertility results yet
Okay.
and want to start LD next week.
Okay.
We're assuming
Yeah,
LD is
Lupron
Lupron
Depot.
Depot?
Yeah.
If fertility comes back positive,
Yeah.
I think you had mentioned I can treat infections while on LD, but wouldn't be able to
Retest.
retest
Right.
after starting Lupron Depot.
Right.
Can
Right.
you elaborate?
Yeah.
Thanks. You two are the best fertility doctors.
That's why you wanted to finish that one.
Just have to put it out there.
Yeah. Hey, you got the LD.
got
I
the
missed
LD.
that one. Yeah. I was still asleep from last night. All right. So here's the problem. When you do any testing of microbiome, we use Fertility, but it doesn't matter which company you're using. When you do a microbiome test and you find out there's something wrong, you got to treat it. So when you treat it, you're going to end up taking antibiotics for whatever period of time your doctor believes in. And then you got to take probiotics. And then in order to make sure it's cleared, technically speaking, you need to retest. How do you retest? Well, different companies use different techniques. Fertility says collect menstrual blood. So you actually wait for your period and you collect it in like a Diva cup and you send off the actual menstrual blood and fluid to Fertility for them to analyze. Emma and Alice requires a swab and a biopsy. So they do it a totally different way. So you could get a biopsy and send it to Fertility. I've never done that before, but I'm sure it would work. But they want menstrual blood. The problem is if you take Lupron, I can't make you have a period unless I put you on the birth control pill and take you off, in which case it negates the whole value of taking the Lupron. So you kind of need to skip Lupron for a bit if you're planning to have another menstruation so that we can get another sample and send it off for testing. The alternative, which is kind of wretched, is to wait for the Lupron to wear off in 3 months, collect the menstrual blood that you get with the start of your stim for your FET, and then end up collecting that sample and sending it, praying that it gets run in time and that you get the answer quickly enough before you do your embryo transfer. Or if you have enough embryos, arguably you could say, well, I risked one embryo and I was comfortable with that. So it depends on how many embryos you have and what the timing would be like. But we generally want to make sure you're clear before we shut down your cycling and your periods.
Love you both,
Aw.
Dr. V and T.
Thank you.
What IVF med protocol would you use for low AMH 0.91 but normal AFC between 9 and 10? 38 years old, concerned about egg quality.
Microdose flare, Recavel and Menopur, testosterone priming, DHEA priming for 3 months, human growth hormone if you can afford it. Those were all good choices. We wouldn't use super high doses, but reasonable doses. And yeah, lots of vitamins and supplements, your coenzyme Q10, your DHA, your pregnancy vitamin, your prenatal vitamin. Yeah, all that stuff. Vitamin D, iron, the basics.
What is a natural IVF cycle?
So natural IVF cycle is where we don't give you stimulation meds. So in most IVF cycles, at the beginning, you're taking a whole bunch of medications, injections, boom, 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 to try and get your eggs to grow, because you normally naturally will only produce one egg. But in an IVF cycle, traditionally, we've tried to make you make many eggs. In a natural IVF cycle, we kind of go back to basics and say, maybe you don't need to make many eggs. Maybe we just need to help you a little bit. Harvest the one egg you naturally select, which is supposedly the best, and your body knows how to do that. Turn that into an embryo and then take that and put it back inside you. So that's a natural IVF cycle. It's essentially taking virtually no medication. Now, we traditionally use a couple of days of meds because when we were doing true natural cycle IVF, a lot of the patients would release their egg before we got to them. And I didn't really love that. So we went back to doing a couple of days of meds. So we would wait till you were like 13, 14 millimeters. We give you just a minimal amount of Menopur and one Cetrotide, and 3 days later we trigger it. We get great eggs, great embryos. It's very similar to doing a natural cycle. It's like a modified natural.
Hey, T and V.
I like the T first. That's cute. Yeah. All right. I know you're just like you're rubbing it in now. Yeah.
I don't ovulate on my own.
Okay.
Age 29.
Okay.
AMH 79.
Woo!
Letro equals no response.
At what dose?
Menopur made me over-respond. 9 follicles. IUI cancels.
Yeah.
Anything else I can try or do? I just have to wait for funded IVF? Or do I have to just wait for funded IVF?
Yeah. So there are different doses of letrozole. That's a reasonable approach. You should consider augmenting with the supplements. So coenzyme Q10, NAC, inositol, resveratrol. Sometimes they can make you more responsive. Metformin, if weight's an issue, that can help as well. If you want to go a surgical route, you could try ovarian drilling. I never recommend it, but it is cheap because it's free. And then, yeah, the only other thing is different doses of letrozole. So you can go up to 10 milligrams. There are also people that will respond to Clomid when they don't respond to letrozole. So that's another option for you. Barring all of that, yeah, you could try a super low dose of shots. Like, if Menopur 75 was too much, you could try 37.5. Or try the letrozole first and then add in the Menopur. So a couple of weeks ago, it was a month and a half ago now, we reviewed a study on the show where we ended up giving, or they ended up giving the letrozole or even a natural cycle. And then on day 8, 9, and 10, 8, 9, and 10, they gave just 75 units of Menopur. And then they triggered when the eggs were ready, and they ended up having a doubling of the success rate. So you could try something simple like that to see if that works. That might work for you.
Is there such a thing as too high progesterone levels post-FUT transfer?
Definitely. Yeah, for sure. Too high a level and you're basically on birth control and you've got endometrial asynchrony. So You don't want to be too high. Now, you do need to be higher if it's endometriosis or adenomyosis, but if you're not endo-adeno, you can go over the top. Yep. We try and cap out at about 100 nanomoles, which is about 30 nanograms per milliliter. So that's what our values are. Everybody's different, but those are the numbers we use.
What's poppin', T? What's poppin'?
What's poppin'?
I like that.
Yeah. The fortune cookies we ate before we
That was
showed up,
not
that was
poppin'.
poppin'.
That was not poppin'. One pops, one flops. They don't know me.
That was priceless.
Dr. V, you rock.
Thank you.
So I'm popping,
It's
you're
a,
rocking.
and I'm rocking. Yeah, it's a
Yeah.
team effort. Yeah, any rocking I do is in large part due to all the prep work he does. So there you go. Yeah.
I recently had positive beta post FET.
Oh, congratulations.
Thoughts on taking these during pregnancy?
Okay.
CoQ10,
Sure, no problem.
probiotics,
Absolutely.
vitamin C,
Definitely.
melatonin.
Not a problem.
Also,
Okay.
regarding TSH levels in
Yeah.
pregnancy,
Yeah.
what level is too high / risky?
You want to keep it under 2.5 to optimize the fetus's neurodevelopmental outcomes. And you don't want it where your TSH, or sorry, your T4 is too high, which is depending on which lab you're using, like 22, 23. So you need a T4 level as well as your TSH.
That's what's popping.
That's what's popping.
That's what's popping.
And rocking, I guess, too. Popping and rocking.
Hi, Dr. V and T.
We were kind of rocking last night.
Absolutely
That
rocking.
was fun. Yeah.
Absolutely
Yeah.
rocking.
Yeah, that was good.
Is it worth it to consider a hysterectomy,
Hysteroscopy?
yep, with a biopsy to rule out endometritis?
No.
If I've already recently completed PID treatment for a possible infection from SHG,
Oh.
feeling nervous.
Wow. Okay, so first of all, I'm very sorry you got a PID infection from a hysterosalpingogram. Yeah, you should be doing full microbiome testing. Never do biopsies. Biopsies are useless for people that are testing for endometritis. That's proven. There isn't even an agreed upon definition for pathology to confirm what acute endometritis is. So never do a biopsy. Just do DNA testing, Emma Analysis, Fertility, any company that does microbiome testing, but using PCR. That's the right way to do it. Excuse me.
Any harmful side effects of taking fragment injections during the first trimester?
No, I mean, in theory, if there was like a traumatic event or trauma, you'd probably increase your risk of a subchorionic hemorrhage, but otherwise, no. We use fragment in loads of patients for a variety of reasons. Thrombophilia patients, patients with recurrent failures, previous history of severe preeclampsia, that kind of thing. A lot of those patients, lupus patients, anyone with anything significant like that, we'll use it for all of those people.
Hi, Dr. VNT. How often do you need a round of Lupron Depot and letrozole for suppression? A round for each FET retrieval or just once every 6 months?
Well, we do it for 3 months, and the effect is probably going to last at least a little while if you're avoiding estrogen supplementation. So I'd probably say, you're good for several months after you've done 3 months of Lupron and letrozole. It would take a while for endo to grow back because you're predominantly keeping your estrogen levels low if you're following an endo protocol and progesterone levels high. So you should be suppressing the endo predominantly. So I would say like 3-4 months is probably reasonable before you have to re-suppress again. But there is no data on that. That's me trying to rationalize. There's no data.
They found 2 mutations in my genetic tests
Okay.
and want to do carrier screening. What does that mean, and how does it affect my ability to get pregnant with a successful outcome?
So I'm kind of confused because it sounds like you had carrier testing and now they want to do carrier testing. So if you have 2 genetic mutations, that's not part of a previous question?
First question I see. from this user?
So if you had two mutations, usually that means that you had, like, for example, cystic fibrosis and, I don't know, congenital amaurosis or something like that. So then they might want to do comprehensive carrier screening and match you to your partner or your sperm source or egg source, whatever the situation is, and make sure that those people don't also have the same thing you do, so that you're not producing a child that's potentially in harm's way. If you're talking about something else that you've done, for example, you had, like genetic karyotype testing, comprehensive carrier screening is not indicated if you had karyotype problems. So that's a different story altogether. I need more details. Maybe DM me and I'll answer you.
Progesterone was 3 times higher than normal on day 3 of period without any medications.
Day 3 of period? Okay.
What could be the cause of this?
You're either getting progesterone or you're pregnant. Those would be the only 2 reasons. There is no other reason. You're probably pregnant. Go get your beta tested and make sure you don't have an ectopic. So there is no other reason. You're either taking Proj, or you had a very wonky period, which would be bizarre, but I guess in theory it could happen, or you're probably pregnant. So pregnant would be number 1.
Would taking metformin for PCOS during pregnancy lower the risk of gestational diabetes?
Yeah, it probably does. There are studies that have done that and looked at it. I don't think it's crystal clear, but it is probably going to reduce your risk of diabetes. We don't have 800,000 people watching, do we?
800,000? No.
But a lot.
But you have questions.
Okay.
Um,
That would be like a stadium.
yeah.
That would actually be like several stadiums.
I think that's
That'd be like 8
next week.
stadiums.
Next week.
Yeah. Yeah.
Do you have patients in the U.S.?
Oh, we have bucket loads of patients in the U.S. More and more every day. We just received embryos from Texas today. Yeah, we have tons of patients from the States. More and more are coming. So we're cheaper. We're very hands-on. You actually get me, the doctor. You get my lab director, who's amazing. So yeah, we have many U.S. patients. Yeah, it's probably 20% of our practice now.
Howdy, Dr. V&T.
Speaking of Texas,
See that? I timed that well.
you did time that well, yeah.
Is ovulation induction ever appropriate for unexplained recurrent pregnancy loss? REI mentioned it as an option, but I haven't found the evidence for this. Don't want to waste the moolah.
No, that's not going to make any difference whatsoever. If you have unexplained recurrent pregnancy loss, you need a recurrent pregnancy loss workup, which has no benefit whatsoever from doing ovulation induction. I think that would be maniacal. That makes no sense. That's one of those tweets that,
right?
yeah.
Really?
Okay.
The minute you said maniacal,
I
said,
know.
You know what? We should have saved this.
So Tarek wants me to do a series of posts where I look at the protocols or suggestions of other doctors without naming anybody and look at it, and if it doesn't make any sense, go, that doesn't make any sense. So yeah, that doesn't make any sense. Ovulation induction is not useful for patients who have unexplained recurrent pregnancy loss. Investigation is helpful. Certain types of treatments are helpful. For example, IVF with PGT, that's one of the rare times where I actually do tell people they should consider going directly to IVF. But yeah, other than the techniques we use or the tests we use, just ovulation induction is of no value to you. Even ovulation induction with insemination would be of no value if the problem is recurrent pregnancy loss.
What should be the progesterone dosage for a combo of endometrium plus PIO in a natural FET? What is the max threshold for prog? I know that beyond a certain level, it becomes birth control.
Yeah. So we use 30 in US units and 100 in Canadian units. Dose it, that's for the level. Dosing, so if it's a natural FET cycle where you're actually letting your egg release, you got to be super careful. You got to start your proj high and then get ready to quickly bring it down, because as your corpus luteum, which is the cyst that's left over from your egg release, starts to produce progesterone and you're taking progesterone, you can very easily overshoot and get a high level. So what you actually want to do is start high with your endometrium and PIO, which is what we call exogenous progesterone. So you want to start high with your exogenous progesterone and then bring it down as your natural progesterone is going up so that you don't overshoot the mark. What would I use? Endometrion's 3 per day. So I would start with 3 per day because it's vaginal. It's not going to make much of a difference in your bloodstream. PIO, I'd probably start with 50 milligrams a day. And then when you got to day 3, I'd probably be looking at dropping it down to 25 or something like that. Maybe even sooner.
Hi, Batman. And
Robin.
Batman. The people understand. They understand.
Oh, that one is priceless.
They understand.
I love that. I love that. I was going to say I'm probably Robin. He's taller than I am. So yeah, okay, fire away.
Patient and fan here.
Excellent.
This is great.
This is
and
great.
they recognize me as Batman. These are all the markings of an incredible individual.
Yeah, there you go.
DQ Alpha complete.
Okay.
Match protocol. Will I ever be able to carry our baby?
Oh boy. So we talked about this earlier in the show, and the answer is probably yes. It does take some evaluation and investigation and treatment and stuff like that. So, but generally speaking, yes, it's definitely possible. It does take a lot of treatment. It can take a lot of therapies. You could have failures, but yes, it is possible. Don't hang up your uterus just because you're a DQ alpha match, even if you're a full DQ alpha match.
I never recommend hanging the uterus.
No, don't hang the uterus. Yeah.
Doesn't sound right.
No.
Yeah.
No.
What about 450 of Gonalef for a hypo, and previous poor responder?
No, I wouldn't. It's a really high dose, guys, especially 450 of straight Gonalef. I wouldn't do that. We try and cap out now at a max of 187.5 of Gonal and like 187.5 of Menopur. Hopefully it'll be available again. Occasionally I'll go to 225, but for the shortest period of time possible, or for someone that demonstrated that previously they needed that higher dose. But generally speaking, those high doses are not good for the egg quality. So we are very strenuously trying to avoid them. I would be much happier dropping my prices and making people do more cycles of IVF where we will get better quality embryos than forcing people to try and cram it all into one cycle because it's too expensive. We're probably at the limit of what we can do with our pricing right now. But if someone came to me and said, I want to do 2 cycles, we actually have duostim. So you save like 37% doing a duostim cycle with us for your second cycle. So we tried to build that in there for those people that just don't want to take super high doses and actually want to take a lower dose, but try and get better quality embryos. Taking them sequentially is fine. If you take, a total of 300 in this cycle, and then you do it another cycle and you do another 300, that's fine. But if you're doing 450 or 600 in one cycle altogether, that's not a great plan for your egg quality, for sure.
Does the day of the embryo affect your chances?
Well, this is controversial. So we just reviewed that a few weeks back, looking at day 5 versus day 6 for the same graded embryo. And in that study, they actually said the day 5s were better. There are lots of studies that say some are good. Like some studies that say, that day 5s are better, and some studies that say that it doesn't make a difference. The one I found most interesting was the one that said, if you are going to do day 6, you need to use an extra day of progesterone because there's a higher rate of miscarriage if you put a day 6 embryo in after 5 days of progesterone. So we now put our day 6 embryos in after 6 days of progesterone.
What would you suggest
Okay.
for a patient after multiple failed transfers of tested embryos? I've had endometrial biopsies and had a laparoscopy in July.
Well, endometrial biopsies, I don't believe in. So you should do fertility testing, check your immunology, and check your microbiome. It doesn't have to be fertility, by the way. Any company that does that testing is fine. I don't support any particular product or company or anything like that. We're super neutral here, but we use fertility just because I like them. They're cheap and they do a good job. So yeah, you could use any service that will get you reproductive immunology testing and microbiome testing, and then I would need to know lots more about you. So these are the cases where I spend an hour and talk to the patients and figure out, could it be a sperm issue? Could it be a lifestyle issue? Is there smoking? Is there drinking? Is there marijuana use? Is your blood pressure okay? Are your vitamin levels appropriate? Are you stressed or de-stressed? There's a new study that's out showing, again, and we reviewed this, I think it was probably a year ago, but there's another study out now showing something as simple as your sleep has an enormous impact on your success rates. So there are all sorts of things we spend a lot of time checking to make sure you are getting a customized protocol just for you to make sure you're going to get the best outcome. And then again, that's the other thing. Your protocol is everything. If you're using a conventional stimulated hormone replacement FET, it literally has the lowest success rates possible. No one should be doing those anymore.
Are Bath and Body Works products safe to use during pregnancy? Specifically,
Oh, jeez.
the hand soaps
You lost me at Bath and Body
hand
Works.
sanitizers.
So hand sanitizer is probably safe because you're not absorbing that much alcohol, but I wouldn't be doing it every 2 seconds. Soap and water will do the same thing. It has no harm. What about all their products? I don't know. I can't answer about all their products. Hand sanitizer used in small quantities is fine. Excessive amounts, probably not a great idea for anybody. Soap and water is good.
Hi, my favorite people.
Oh, that's like significant. Thank you. Yeah,
I
that's
appreciate being a favorite people.
I appreciate being a favorite person too. Yeah.
DHEA level 294. And
Okay.
testosterone 76.5 ND over DL.
Yeah.
After 2 weeks of DHA supplements, no other signs of PCOS, and usually T is very low. Discontinue DHEA?
No, we don't even bother measuring our DHEA levels. So I would just stay on it. And like all the studies that looked at DHEA, none of them actually measured the DHEA levels. Don't worry about it. The benefit is coming from providing androgen substrate for your eggs to use to convert into estrogen. So don't bother measuring your levels. The more substrate that there is, the better you're going to do. It's like, I don't know, you're trying to build a Lego castle. The more pieces of Lego you have, the easier it is to build the castle. You're not reaching constantly to find the one piece. There's thousands of them. It's the exact same thing. I only say that because my kids made me put together the Lego car, which I love. My kids bought me the Lego Ferrari. It's awesome, but it's got 3,800 pieces and it's taken me forever to put together. But it's very cool.
Hi, Dr. Victory.
No tea? Oh, no, you're not feeling the love. Do you want a hug?
I think I'm not going to read the rest of it.
Do you want a hug, buddy?
Kind of going downhill here.
Yeah.
I've had a few chemical pregnancies and miscarriages.
Okay. I'm sorry.
I have PCOS, but almost every typical RPL test has come back with no answers.
Okay.
OB does not want to do laparoscopy, but I do. Thoughts?
Well, laparoscopy you'd only be doing if you thought you had a problem with your fallopian tubes, because that's probably the only reason you'd have recurrent pregnancy loss, like hydrosalpinx, something like that. Hysteroscopy, you could argue, would be reasonable to look for a septum or a T-shaped or Y-shaped uterus or some kind of anomaly. Again, I would be talking to a RE at this point if you have recurrent pregnancy losses, because we do a whole other level of testing than an OB will. And I have to admit, even amongst the fertility community, there are differences in management of recurrent pregnancy loss patients, with some of us doing more testing, others doing less testing, some people going straight to IVF, other people, myself included, refusing to do IVF until we have more testing so that we know what's actually wrong. So you're going to get a lot of different answers on this one, but I think the important thing is that you get appropriate consultation first and then consider appropriate testing second, and then therapy would be third. And there are things that can be done. Laparoscopy would probably be one of the last things I'd ever consider for someone with RPL. Hysteroscopy, sure. But even that I would only do after I had done a saline infusion sonohystogram. So food for thought.
Ready?
Born ready. Like I jumped out of my mama, I was like, where's the action at?
Nice one. Nice one. You know what? Good job. That's great. I like that. I might use that.
You might use that
I
one.
might use that one. That's real good.
What up, people? Yeah.
Hi, Dr. T.
Oh, ouch.
NV.
Yeah, we don't want to get in trouble. He is only a doctor in his own mind and mine, and nobody else is, okay?
Well, there's rumors around the office that Dr. T is in the office today.
Yeah, that's true. You got called Dr. T today by one of the staff, yeah. By a very important staff member.
Right?
Yeah.
That's high ranking.
That's high ranking.
How many months of human growth hormone do you recommend before starting IVF?
Ooh.
If you had low-level endometriosis, do you still recommend human growth hormone on 45?
So we don't recommend months, just weeks. At 45, arguably it will only be of minimal value to you. The problem at 45 is that the percentage of eggs that are genetically abnormal is extremely high. And as a result of the fact that it's extremely high, it will take an enormous number of eggs to actually achieve one successful pregnancy for you. So that's a tough situation. Make sure whoever you are dealing with has told you that this will be a bit of an uphill battle.
Hello to both. How safe is transferring embryos to your office?
It's extraordinarily safe. We get embryos from all over the world every week. So if not every day. They've come from as far as Australia. We've never had a problem. So it's super safe getting them here. We don't have any issues. Yeah.
I'm 6 weeks. Hi. See how you did that one?
Hi.
Hi later.
Yeah. First, let me tell you about
Let
me.
me get into this.
Yeah.
So again, I'm 6 weeks along. So
Okay.
She backed up and said, let's try this again.
I got it.
Did natural cycle FET
Okay, great.
was told to do 200 milligrams of progesterone suppositories,
Sure.
but I have endo. So I have been alternating 200 milligrams BID with 200 milligrams VAG. Too much?
No. I mean, that's probably less than you need as far as we're concerned, but I would get your progesterone levels checked. So, but if you're pregnant and you're 6 weeks, you probably don't have much to worry about at this stage. So rule number one of being a good physician, if it ain't broke, don't try to fix it. So if there's nothing wrong with what you're doing right now, there's no reason to intervene. Leave it alone.
Hi. I'm 6 weeks along. Did natural cycle FET?
Isn't that the same one?
No?
Oh, okay. Another one. All right.
No, it is the same one. But
Just a different question? Different platform?
No. Just more information, I think.
Oh, okay. Fire away.
The natural cycle FET was told to do 200 milligrams
Yeah,
progesterone
yeah.
suppositories, but have endo.
Yeah.
So I've been altering 200 milligrams BD with 200 milligrams VAG plus 0.5 PIO. Is that too much?
Oh, no. That's what we would do.
There you go.
There you go.
Now you got the whole formula.
Now I got the whole thing. All right.
Dr. V, how long is the wait time to see you right now?
I have no idea. We get people in fairly quickly, either through myself or Dr. Mayrand, who does some of the consults to speed things up. And then I do all the follow-up. So you're still getting into me, but there's kind of a sideways route to getting here. If it's urgent or emergent, you just have to tell the office or tell your physician to mark it as urgent, and then I'll triage what's going on. Yeah. Probably at least a couple of months. I don't want to get in trouble. I've been sworn to not answer timing questions because My office staff threatened to abandon me. Yeah. 9 o'clock.
9 o'clock.
Yeah. A couple more?
Okay.
Is there like an ocean of questions? Yeah. All right. We will do our best, as always. Yeah.
You ready?
Ready.
Okay.
Remember the mama thing?
Yep. Yep. What was it? Popping since birth, or what was it? It was good. Popping since I came out, or
No, I said I popped out and I was like, where's the action?
I popped out, and where's the action? Yeah, that's it. That's good, man.
Yeah.
That's
All
really
right.
good. I'm probably gonna use that today. Don't know how, but I want to use it. I want someone to ask me a question where I can give that answer.
I will ask you a question. Fire away.
Hi, Dr. V.
Yeah.
I'm 37,
Okay.
2 LBS.
2 live births. Okay.
AMH 6.32 milligrams over DL, AFC 24 plus, 12 to 15 chemical pregnancy losses, no clinical losses.
Whoa.
On progesterone, 3-DPO, and baby aspirin. Requested an endobiopsy with the RE. I started seeing earlier this year, and she added BCL6. BCL6. It was 3.4. It also found fragments of polyps in the sample. My doc said she wasn't worried about the polyp because it was a high false positive. Asked for a hysteroscopy anyway. Could this be causing my chemical pregnancies versus endo causing poor egg quality? Get pregnant almost every time. I'm fertile, but implantation seems to be the issue.
Okay, so biopsies are useless. That's becoming the newest catchphrase.
Absolutely.
Biopsies are useless. Endometrial biopsies are useless. We should do a video on
100%.
endometrial biopsies. Yeah.
That's it.
Okay, so you should probably get appropriate consultation from an RE that specializes in recurrent pregnancy loss. You should not be trying anything until you get answers. There is an association with recurrent pregnancy miscarriages or abortions and breast cancer. So it is not safe to just keep getting pregnant and losing the pregnancy. You need answers. To being amazing. So that's something that could be looked at. You could just do a sperm prep and see how well he responds. But generally speaking, if the progression is very poor and the motility is very poor, you're probably going to need IVF. But it's worth trying IUI depending on how well he does after the wash. And that can have a lot to do with his count. If he's got 200 million sperm and 10% are motile, then yeah, you could still get a decent result with an IUI because you'll still get lots of motile sperm. But if he's got 5 million sperm and 10% are motile, there's no way that's going to work with an IUI. The chances would be less than 3%. So in those circumstances, we would say go directly to IVF or do the IUI, but understand your chances are less than 3%.
There's a chance they didn't hear that answer. The previous one, not this one.
Which previous one was that?
The one of the
Why did something cut out?
yeah.
Oh, did you fix it?
Yep.
Oh, okay. Which one was it?
The
We've answered 10
the,
million.
the crystal, this one here, high doc, the polyp.
Oh my God, that one?
Yeah,
Okay, for the
unfortunately.
lady, I'm assuming lady, that the individual that answered or asked the question about the polyp, you need to see a reproductive endocrinologist who specializes in recurrent pregnancy loss. You should stop trying to get pregnant until you get answers. It's actually risky to have that many losses. There's an increased association with breast cancer, so stop until you get appropriate answers. And as far as the polyp is concerned, the polyp is definitely a problem because it's 100% increase in your risk of miscarriage. So you can't ignore that. And I don't know what they're talking about, a false positive. If you have a polyp, it'll show up on a saline infusion sonohystogram. So do an SIS. You don't need an expensive hysteroscopy. If it's there, then you need a hysteroscopy. If it's not there, you don't need hysteroscopy. It's useless. But see a fertility specialist who knows what they're doing specifically for recurrent pregnancy loss. Because there are all sorts of tests that can be done, and they need to be for someone that's had as many losses as you have.
My favorite Tuesday duo,
Oh, there you go.
Dr. V or Intern T.
Intern T.
You know, with that Intern T, I kind of feel demoted at this point. I was really enjoying being a doctor.
You're like the full. You had graduated. In
I was about to get a lab coat. I guess I'm an intern now.
This is really getting to his head, guys. All right.
What is the level of progesterone 7 days after LH surge that will confirm ovulation? I have heard 5, and some people say 10.
Anything over 5 is considered signs of ovulation. Yeah.
Any difference? So, hello, gentlemen. Always amazing to see you and hear you, Mr. T, and the doc. Any differences in the impact of CBD versus THC, medical versus smoking, MJ, when it comes to fertility?
No, they're both terrible. You can't do either one. That's a slam dunk answer. You cannot touch CBD, THC, nicotine, vaping, oils, gummies, edibles. They all gotta go.
How much DHEA per day? 25 or 75?
25 3 times a day, which is 75.
Oh, that's interesting. It's kind of the same.
Yeah.
I have a crazy question.
Okay.
So
That's a good preamble.
great
Okay.
intro.
Yeah. Yep. All right. Well, can we end with this one?
sure.
Are there 10 million more?
Yeah, there's
questions?
10 million. You're not going to get through this.
No?
No.
Okay. Okay. Yeah.
So again, crazy question.
Yeah.
Since I have day 6 embryos,
Yeah.
is it possible to do a transfer on day 5 of an embryo and a transfer on day 6 to ensure I get my embryos in when my endometrium is receptive?
I'm confused.
Me
So
too.
she's asking if
I feel like she wants to go back in time.
She wants to take her day 6 embryo and transfer it on day 5.
No, that's not what it says.
What does it say?
One more time.
Okay.
Again, it's a crazy question.
Okay.
Since I have day 6 embryos,
Day 6 embryos.
is it possible
Yeah.
to transfer on day 5 of an embryo and transfer on day 6 to ensure I get my embryos in when my endometrium is receptive?
I don't get it. I'm sorry. I don't actually understand that question. I'm not sure where that's going. If you have a day 6 embryo, it should be transferred after 6 days of progesterone has been completed. If you have a day 5 embryo, 5 or 6, it doesn't matter. That's the best I can answer you.
People love the Canadian accent.
They love my Canadian accent.
I'm assuming you for sure.
Thank God I don't speak Farsi on these shows because my Persian is heavily accented. So people always make fun of me when I speak Persian because I don't speak it properly. Well, I do speak it fluently, but they can tell I'm not native.
You're not from around there.
Yeah, they can tell I'm not native Persian speaking. Yeah.
Shall I continue?
I don't know. One more because the last one was too easy.
Okay. He wants a challenge. Okay.
You know what I want?
Yeah.
I want everybody to answer for me why the hell Instagram doesn't grow. I hate Instagram. It drives me crazy.
No, I'm not a fan.
Our Instagram never grows. We put up one video on TikTok. We got 800,000 views. 800,000. 2,000 people joined watching us. 70,000 likes. Blah blah blah. We've been chiseling away at Instagram for 4 years now, and we are just level for the number of people following us. I don't understand it.
It's a big phenomenon right now on YouTube. A lot of the big people, in the billions and millions, they also are complaining
about Instagram.
They're like, Instagram sucks. Let's do something else.
I hate Instagram.
A lot of people saying it.
Oh.
You're not the only one.
Yeah. YouTube, love them. We consistently grow. Lots of people watching. We're going to hit 1 million views very soon. TikTok, unbelievable. Boom. Literally 800,000 in less than a week,
it's,
right?
It's wild.
It's been 5 days.
That's the craziest thing I've seen.
Yeah, huge. But Instagram, you can kill yourself.
No love on the gram.
There's no love on the gram. Shall we wind it up? Or you got one more? Tarek's
I can give you one.
Okay.
I don't know about terminal. Terminals is, you're asking a lot here.
Yeah.
Since I don't write the questions, I can give you one, but
all right.
Hi.
Yeah.
Fertility friends.
Okay.
40.
Okay.
With DOR.
Okay.
2 previous healthy pregnancies.
Great.
Most likely cause of recurrent chemical pregnancies are chemical pregnancies implantation failure or due to aneuploidy.
Most likely would easily be aneuploidy. You're going to have about an 80 to 90% chance at 40 with DOR. Yeah, unfortunately. So it's almost overwhelmingly going to be from aneuploidy, for sure.
Easy one, last one.
Oh, an easy one? Okay.
Super easy, but you can get into it a little bit.
All right.
Are you the only doctor in Windsor who offers IVF?
No, Dr. Pattinson, my colleague, also offers IVF. It's just the two of us. Dr. Tomps also does a little bit. So any of the 3 of us can facilitate. Dr. Tomps doesn't do retrievals and transfers. I do those for him, but he does manage some cycles. So yeah, any of the 3 of us would help. I think I'm the busiest, and then Dr. Pattinson, and then Dr. Tomps.
To the day 5, day 6 question, there's some clarifications. Yeah.
Okay. All right.
Some sites say that day 6 embryo should be put on day 5.
Right.
So that's what I wanted to put. 2 different day 6s in on 2 different day 5s as a fail-safe.
So day 6 embryo. So we've reviewed a study on the show. I can't remember what it's called. Day 6 or 7 days of progesterone, which is better. So it's actually kind of named the wrong thing, but that's okay. We'll fix that. So there is a study that showed that if you put a day 6 embryo in on day 5, you have a higher rate of miscarriage than if you put a day 6 embryo in after 6 days of progesterone. So we use 6. That's all I can tell you. I'm not telling you what to do. I'm not telling you anything other than the data that's available. The data that's available suggests that a day 6 embryo is going to give you a better chance of not miscarrying and the same chance of implantation if it's put in after you've completed 6 days of progesterone. So day 5 embryo, you'd finish 5 days of proj, morning of the 6th day or afternoon, whatever you put in your embryo. Day 6, we do 6 days of proj and then put it in. And I think that's a wrap. Do you still have more? We're going to be going forever. Okay. We love you all. Thank you again to all of you who are watching, sharing, liking, commenting. I'm super keen to see how many of you thought that Instagram post with the 6-foot-tall vagina was an art piece. Tarek and I had a good chuckle when we saw that. So let us know what you think about what we do. Thank you for watching. We love doing this show. Stay tuned for some friends to come on. We're going to start taking the show on a virtual road tour to meet other folks and friends out there who are doing some amazing work as well. And we will be back next week with another episode of Fertility Fact or Fiction.